Hi, Madam Melina. Today we are going to discuss regarding your health condition. I received a letter stating that you have a low leg swelling. Can you tell me more about it?
Yeah, doctor, I'm very worried because I have been having leg swelling over both of my legs, and this has been going on for almost 1 month, and I feel it's actually getting worse, doctor.
Okay, I can see that you are very concerned regarding this. Hopefully, by the end of this consultation, I can get to the bottom of this. You mentioned that both legs are actually swelling for 1 month, is worsening. Did it started gradually or started suddenly?
Yeah, it started gradually, like I mentioned just now, and then slowly, day by day, I notice it's actually getting bigger and bigger. I want to show you my leg.
Okay,
It's
sure.
all swollen, doctor.
All right. Besides that, are you feeling any pain over your leg?
If I press it, when it really swell out, I do feel a bit of pain.
All right. Is there any particular timing that this swelling will become worse?
No, it comes throughout day and night. Never really resolve.
Yeah, sure. Anything that you tried to make the swelling lesser?
Yeah, I try to elevate my leg. I felt that it actually helps a bit, but most of the time it come back again.
I see. Anything that you did that you think it makes the swelling worse?
If I walk longer distance, then I also feel the swelling gets small. That's why I think I'm better if I rest.
All right. Is it the first time that you're having this?
Yeah, first time.
All right. Besides that, are you feeling any difficulty in breathing?
Yeah, I do feel a bit of breathlessness. If I walk a long distance, I tend to have to rest for a while before I continue, and this has been bothering me as well for almost 1 month.
Almost 1 month also. All right. You also mentioned that you feel more tired than usual.
Yeah, I do feel that, especially when throughout the night, especially if the whole day I'm walking around towards the late evening, I will start to feel tired as well.
All right. Does sleep actually help with this tiredness?
I think it does help. In the morning, I feel a bit fresh.
All right, sure. Besides that, do you notice any chest pain?
No chest pain.
Any racing? Any racing of the heart?
No.
Do you feel you need to sleep with more pillow in order to feel more comfortable?
I can still sleep with one pillow, but I do feel a bit
Oh,
breathless.
okay, sure. Have you ever wake up at night because of breathlessness?
No.
All right. Have you had any occasion that you are nearly passed out?
No.
All right. Do you notice any increase in body temperature?
No.
Okay. Any sweating at night?
No.
Do you have any changes in your appetite recently?
No.
Any
You mean
changes
you
in
mean
your
change
weight?
in my appetite?
Yeah.
Change in my appetite. I do feel I eat lesser nowadays, but I'm not sure whether is it like
All right.
intentional because I don't feel like eating much.
I see. All right. Do you have any change in your weight?
Mm, I'm not very sure because I thought I gained some weight because of my leg swelling both sides.
I see. Do you have any hot or cold weather preferences?
No.
All right. Um, do you have any joint pain?
Joint pain? No.
Any bone pain?
No.
Or any back pain?
No.
Any muscle pain?
No.
All right. Do you have any skin rash which you newly notice?
No.
All right. Do you have any swelling anywhere else besides your legs?
I think only initially I thought it's just my legs, but nowadays I start to realize that my face when I wake up in the morning is also a bit puffy.
I see. Is it around your eyes also you feel a bit puffy?
Yeah, yeah.
All right. Do you notice any lumps and bumps?
Not that I know of.
Okay. Did anyone tell you that you appear to be more pale recently?
No, no,
Okay. Do you notice you have any yellow discoloration, yellow changes over the white part of your eyes?
no,
Any itchiness?
no,
All right. Do you feel any pain over your tummy?
no,
Any problem swallowing food?
no,
Have you feel like sick and throw up before?
no.
All right. Do you notice any changes in in your water works recently?
I can pass urine same as usual, I feel.
Okay. Do you feel that you go to pass urine more frequently?
Not really. In fact I feel it's
Okay.
lesser.
It's lesser. All right. Do you feel any bubbles you notice in your waterworks in your urine?
Yeah, sometimes I notice my urine is a bit frothy.
Okay. And you notice any blood,
No, no.
any sandy sensation?
What about sandy sensation? No, 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 no. I don't
Yeah.
see that.
All right. Do you have any change in your bowel opening?
No,
Do you notice any blood?
no.
All right. Uh, do you feel your vision is impaired recently? Any
Recently,
blurring?
I'm always have your vision for the past 1 year. The doctor says it's due to my diabetes that's not very well
I
controlled
see.
initially.
I see. All right. I will come to that soon enough. Besides that, I'd like to ask, are there any recent illness like flu or coughing or sore throat?
No, no.
All right. Um, pertaining to your diabetes, may I know how long were you diagnosed with diabetes?
So 2 years ago, when I do some health screening, I was told it was normal. Then subsequently, about few months later, uh, the doctor did told me that my sugar is on the higher side. So I always thought, and because my mother and my father also got diabetes, that's why I went for health screening. I only realized I got diabetes 1 year ago.
Okay. May I know what
But actually, I'm
medication you
not
are
taking any
on?
medication. Yeah, yeah,
I
I'm not
see.
taking any medication for my diabetes.
Okay. Did you seek for any medical advice on your diabetes?
Not really.
Okay. So you have never seen a doctor for your diabetes?
Yeah, only when I know I got diabetes, but I think I'm trying with my diet control and see how it goes.
Okay. Did you have any extra blood tests which can tell how is the control of your diabetes, like the 3 months control?
No, no, no. I didn't do that.
Okay, sure. Are you besides this diabetes, are you having other medical condition which you need to inform me?
No.
All right. Are you taking any medication?
Not doctor prescription. No.
Okay. Are you taking any over-the-counter medication?
Doctor, I'm actually to be honest, I took some traditional herbs as well lah. But that is
Oh,
after the leg swelling comes, I feel a bit worried. That's why I decided to take it for the past 2 weeks.
okay. May I know what is it for actually?
Mm, I think it helps with it's so called it can help with some form of swelling lah, but it doesn't really help. That's why I don't know whether I should continue.
All right. I believe you might need to stop the medication. Uh, Prior to that, may I know for your diabetes, were you do you have any chest pain, or you were told that you have heart attack before?
No,
Any one-sided body weakness?
no,
Have you ever felt your hands and legs are a bit uh, reduced in sense and sensation, like you're walking on a wool or cotton?
sometimes I do feel my feet are a bit numb, but I don't know whether it's because of of my leg swelling.
All right, sure. Um, you mentioned to me that your father and mother are having diabetes. Is there any other medical condition that runs in your family?
Medical condition not that I know of, but my father does have colon cancer, but he passed away because of that as well.
I'm sorry to hear that. Okay, Madam Elena, is it okay if I have a look on you?
Yeah, sure.
Okay. So just like to have a look on the patient. Is she a well built or medium built lady?
She's an average built lady. There's no photo. But she's a bit puffy. There's pre-orbital edema.
All right, sure. I go ahead to look at the hand. Any clubbing?
No clubbing.
Any thin skin?
No thin skin.
Okay. I would like to palpate for the pulse. Any abnormal rhythm?
Pulse is regular.
Okay. I would like to check for proximal myopathy.
Okay, there's no proximal myopathy.
Okay. I have a look on the eye. Just confirm the puffiness.
Yeah, there is a puffiness.
All right. Let's check for pallor and jaundice.
No pallor, no jaundice.
All right. I'm going to check for cervical lymphadenopathy.
Yeah, cervical adenopathy, when you palpate, you don't feel any lymph nodes over the cervical region.
Okay. I would like to auscultate the chest for any reduced A and G bilateral lower zones, suggesting a pleural effusion or fine
So when you
crepitation.
auscultate, you only want auscultation. Okay, you only want
Yeah,
auscultation. When you
I'm running out.
auscultate, yeah, the lower zone is actually full of crepitations.
All right, sure. I would like to have a look on the abdomen.
Okay, 2 minutes
Any
left.
hip, yeah, any hepatosplenomegaly.
When you palpate, you don't feel any spleen or liver enlargement.
Also to below the kidney.
Okay, when you biopsy the kidney, you don't feel any kidneys.
Okay, I like to look for ascites.
That's not really any ascites.
Okay, I go down to the legs and to confirm the pedal edema.
Okay, yes, there is a pedal edema.
Any is it tender? Any redness over the skin?
There's no tenderness. It's actually pitting, as you can see.
Okay, I would like to offer for a postural BP.
Examiner say no need, not important.
Okay, yeah, Madam Alina, may I know what is your concern?
Yeah, doctor, what do I have?
Madam Elena, I think from what I've examined you and interviewed you and the blood test that attached by your GP, we think that you are probably having a kidney problem, which it can be something new or it can be something old, which I couldn't tell at this point of time.
Oh, but what is the cause of my kidney problem, doctor?
There are multiple causes. The first thing I'm thinking is actually your diabetes causing a leakage over your kidney. It's a common knowledge that actually if a diabetes is not well controlled, there will be a leakage in the kidney and causing the kidney function to be worse. And as the protein leak out from our body, the water will accumulate and then presented as a leg swelling also.
Doctor, what is the next step for me?
Okay, Madam Elena, I would think, is it okay if I admit you to the hospital? We
Time's
need to
up.
do some, all right.
Okay, time's up. Okay. So yeah. So would you mind to summarize important points in the history as well as examination, and then only you give your provisional and differential diagnosis. You can start with history
Okay,
first.
okay. Madam Elena presented with a 1 month history of a bilateral lower limb swelling, and also associated with a reduced effort tolerance, shortness of breath, and also showing signs of frothy urine. And she was also diagnosed with the diabetes and was taking traditional, and he also has history of taking traditional medications. So putting all this together, I would like to offer a different a
How about
provisional
examination?
diagnosis of from examination.
Examination first.
Okay, as examination, this patient shows uh, clinical signs of
This is a
fluid
positive finding.
overload. Yeah, fluid
Mm-hmm.
overload as
What
the
kind of
patient
fluid?
has a bilateral. She has bilateral crepitation as well as bilateral lower limb edema along with facial puffiness, suggesting a fluid loss to third space,
Okay.
which is likely due to hypoalbuminemia. My unifying diagnosis
Mm-hmm.
for this patient would be advanced, chronic kidney disease secondary to diabetic nephropathy.
Okay. What
And my
is your
yeah,
other differential diagnosis?
differential diagnosis would be acute kidney injury, likely which could be secondary to traditional medication.
Mm-hmm. Any other differential?
Um, I would also like to rule out heart failure. However, this patient does not have any uh, symptoms suggestive of a previous cardiac event. However, in patients with poorly controlled diabetes, they may have silent MI.
Okay.
And
But
I would
what's the
also
chief
like to,
complaint? It's a bit swelling.
it's a bilateral lower limb swelling.
So, judging that you're thinking that this patient has chronic liver disease, what kind of syndrome that you are dealing with?
Sorry again.
You are saying that this patient has some form of chronic kidney disease. What kind of
Yeah,
syndrome they are dealing with?
I'm thinking more towards the advanced diabetic, advanced diabetes and advanced
No,
uncontrolled
see,
diabetes.
you say patient is fluid overloaded,
More,
see,
yeah,
and
it's more
then
to a nephrotic,
nephrotic syndrome. Okay, so what are
nephrotic
the other potential explanations? You said about drugs, diabetes, any other things that I need to
Uh,
consider?
I've also tried. I've also tried to explore recent infection, which there was none,
Mm-hmm.
and
Okay, no other.
I will also need to explore for
Mm-hmm.
the other in infective conditions such as hepatitis B, C, and also underlying malignancy. I've tried to screen for malignancy,
Mm.
but there was no suggestion of that.
Okay, how will you investigate this patient?
I will start with basic blood works. A full blood count would expected to be have a normal chromic normocytic anemia. Renal profile which has been attached. I would like to add on with a venous blood gas to look for any metabolic acidosis. Liver function test is for the albumin level as well as to look for any transaminase raise in transaminases. Subsequently, I would like to request for an calcium magnesium phosphate along with an intact parathyroid hormone, which can actually tell is a acute kidney injury or chronic kidney disease. Subsequently, I would like to request for HbA1c for the control of diabetes, followed by a chest X-ray to confirm there are bilateral pulmonary edema, ECG to look for any ischemic changes, also an ultrasound of the abdomen to look for the kidney structures and the size of the kidney as well. Also to rule out any obstructive cause in causing acute kidney injury.
How do you manage this
Um,
patient?
this patient should be admitted to the hospital, managed in a multidisciplinary approach. To begin with, you secure the airway, breathing, and circulation, starting with patient education, referral to the dietitian, smoking and alcohol cessation and vaccination advice also. Subsequently, the patient should be started with diuresis to remove the,
Okay, time's up.
remove the excessive. Yeah.
Yeah, time's up. But just continue. I just want to see how you work out for this patient management.
Okay. So
After the diuretics.
to give diuresis also for DVT prophylaxis, and also to work out for the underlying cause causing this either this acute or chronic kidney injury. Subsequently, we need to refer to endocrinologists for a good diabetes control, diabetic nurse, and also pharmacists, and also subsequently a referral to nephrologists in terms of CKD retardation. And also
Okay.
to advise the patient to
So
stop taking the herbal medication.
yeah, yeah. Actually, if you don't have time, right, time is always inadequate in the exam, right? You need to prioritize which is the most important points. So the not so important one, you can just, if you got time only, you mention. Vaccination in this patient at this moment, definitely not. Okay, not important to mention. You should mention something more important. If you want to mention about management, right? I would say that I will admit this patient, and the patient will need to further work up. Okay, I need to offload the patient. The management will be multidisciplinary approach focused on patient education and counseling. I'll refer a nephrology team for co-management. We need to start the patient on diuretics, make sure the oxygen level is adequate, and also need to, depending on the etiology, I may need to consider the role of kidney biopsy, and the subsequent management, targeted management will depend on the etiology. You can mention like that, okay? If you don't know what is the cause and the examiner didn't prompt you, but you need to be a bit faster. Oh, so this is too, I would say, not very exam oriented at the moment, but it can be improved. I can see that you're quite fluent. So you see, if you go back to this scenario, right, I feel like you are missing something to me is quite important. So you agree that this is a nephrotic syndrome?
Yeah.
Hello? Yeah.
Hello. Yeah.
You think this is a nephrotic syndrome, right?
Yeah.
Yeah. But why don't you just mention this is a nephrotic syndrome? Can be this patient can have chronic liver disease. Can be chronic heart failure, chronic liver disease, which is less likely because given that there's no history to suggest that. I think it's point towards chronic kidney disease, in particular nephrotic syndrome.
All right.
Okay, and then nephrotic syndrome got multiple causes. So you mentioned about drugs, you mentioned about diabetes, uncontrolled or poor control diabetes. What else? What is the other cause of nephrotic syndrome? Nephrotic syndrome got primary and secondary, right?
The other nephrotic syndrome when it comes to all the
All
biopsy
the
kind
what?
of, histology,
No, it's not
histopathology
biopsy, it's
diagnosis.
clinical history. You still need to go back to history because bear in mind that nephrotic syndrome can be membranous, can be minimal change, can be FSGS, right? So
Okay.
in membranous in particular, you really need to screen for connective tissue disorder and also so-called secondary causes, which include the malignancy. How you screen for malignancy? I heard that you already said you screen for malignancy, right? This patient got reduced appetite, not sure why, not eating much, but weight very static. Also bear in mind that the weight may not be a good indicator in this patient because she's gaining weight at the same time she's also losing weight. And that's the only question you ask about malignancy screening, which is
I think I
weight loss and appetite loss.
I think I asked about the hematochezia, and
What did you ask?
I tried to ask about the lumps
Hematochezia.
and bumps. I mean, I asked the blood.
Lumps
I
and
asked
bumps,
specifically any. Yeah.
yeah, lumps and bumps is a very general question. Do you have any swelling over any parts of your body? Yeah, you can mention that. But this kind of patient, because some patient they may not realize, some surrogate may not realize that you are hinting towards that, unless it's a very trained surrogate. Most of the time it's not very well trained because it's always like last minute train, and then the surrogate only go by the script. And this is an exam. So you need to really ask a specific question. So in her age, what are the malignancy you want to suspect?
It's more to gynecology and also breast CA.
Yeah, how do you ask the best CA?
I think I need to ask for breast lump.
Yeah, exactly. If you ask me breast lump, I would say yes. Actually, I noticed that recently, I have this lump over my lower part of my breast, left side. Do you surprise if you miss this?
Yeah.
Yeah, because if you're going to change your differential and going to change your diagnosis, you see, so it's very important. Although often most of the time in the scenario, right, there's not a very, it's always there's a lot of this red herring and also lots of differential to consider because the idea is to train your thought process and try to find which is the most likely provisional diagnosis. But at the same time, you also want to put those possible diagnoses under your differential. You cannot miss that. And it's not just breast lump. You also need to ask. You ask about any blood in your stool. Yeah, that can be. But bear in mind that gynecological disorder. How do you ask? How is your menses? Remember, all the female we need to ask about the menses. This patient is like 50 years old, already reaching menopause. So if you ask her, she will tell you that actually she have no more menses already. And if you have no more menses, is there any like bleeding from the private area? You have to ask in particular to look for any postmenopausal bleed. Although this 50 years old is at borderline, it's like reaching menopause, may or may not still have a bit of period. But you still need to ask this kind of question to screen. You see, it's not enough to just malignancy or weight change, appetite change, night sweat, bone pain. That's all. No, it's not. It's not automatic or robotic like that. You need to think what is the appropriate malignancy at her age. So common one is still the, for example, female is a breast, and then GI, GU, okay, and also you ask about altered bowel habit that can also related to GI. Another thing is that lumps and bumps. Yes, you can ask that. Okay, you can see that some examiner don't like lumps and bumps. Some don't bother. But the idea is you need to ask whether you notice any swelling over any other over your all parts of the body, any parts of your body. You can just ask a very random question. If you want to ask about do you have lumps or bump in your body, it's fine. But you need to ask a bit specific because sometimes this kind of question is not commonly being being conveyed to actually ask about any lump inside the other place of the body. Okay, so again, when you ask, right, this patient actually, yeah, you get most of the history. The only thing I'm not happy is actually you didn't screen for malignancy in detail. Okay, because nephrotic syndrome you cannot escape with malignancy screening. Examination, I think is fine. You got most of the point. But of course, if you got the history of left breast swelling, then you should offer to check the left breast. But in exam, even in exam, usually there will be a chaperone. You want to check, usually the examiner say there is a breast as a mass. So sometimes can be skipped. But in the real exam, if you expect to check, you should check. You should offer to check by the four quadrant just to say, ask the patient to point to you where is the lesion and then you just feel for it. That's all. Okay. If let's say that is lah. And then bear in mind, I have mentioned this countless time. You are dealing with someone that's newly diagnosed or untreated DM. You should also ask to check for urine dipstick and bedside sugar. None of that mentioned. I have spoken it so many times for our previous session. To make you look better and different than others, you should mention that I would immunization by checking your urine dip as well as the bedside sugar as well. And then you go back and talk to the patient. You just tell this to examiner, it's fine. Okay. And then when you mention about differential analysis, it can be nephrotic syndrome. And look at the kidney function outside. Urea is 9.1, creatinine is 270. That is so-called renal impairment. You don't know whether it's a AKI or this is a CKD progression, but this is definitely a nephrotic syndrome with AKI component or renal impairment, you can say. And the cause can be due to diabetic kidney disease, membranous nephropathy, possible can be due to breast cancer or undiagnosed breast malignancy. It can also be due to Chinese herb medication. Commonly, it's called as erythropoietic acid nephropathy, but you don't know mention that is fine. You just mention that can be due to drug induced, for example, because of the Chinese herb usage. Can mention about that, okay? And then the workup for the nephrotic syndrome is not enough. You need to mention you want to check for renal function, and you can also offer VBG as well, venous blood test to look for any acidosis, liver function, like you say, albumin level. And then you need FEME. I didn't hear you mention anything about protein quantification. Perhaps you mentioned about UFAM, but there's no protein quantification. If you think this is nephrotic, you should quantify it. UFAM, UPCR, and then 24 hours urine protein. You want to mention UACR is even better. And then HbA1c you mentioned. Also look for viral screening, tumor markers, myeloma screening, ultrasound KUB with Doppler because why? Nephrotic syndrome cause AKI, you need to rule out renal vein thrombosis. You see, I've mentioned in the previous session, nephrotic syndrome has risk of thrombosis, venous thromboembolism. That can also include renal vein thrombosis, not just DVT or PE. Okay, therefore, in this kind of patient, you need to do an ultrasound therapy with Doppler to look for the. I don't need to know about that resistant index or velocity, but I just mentioned about the Doppler. And then at this particular patient, you want to screen for breast ultrasound or even mammogram, and then consider through-cut biopsy and CT staging. So the management, like I said, because you should mention that you have to stop the Chinese powder, advise her to stop, admit, offload, monitor her kidney function, and refer nephrology team for consultation, biopsy, and further workup. As well, for this patient, if you explore that there's a breast lump, you should also refer the breast surgery for a role of through-cut biopsy and subsequent management. Just mention like that. You can see that your consultation history taking is too long. I'm talking about at 9 minutes, you are still in HOPI. This is too long again. So you need to ask a very concise question. If you cannot finish a history taking by 15 minutes, an examination by 15 minutes, right? Can you imagine or not how we do the old format, everything in 10 minutes? It's not possible, right? So you know how we are trained. We are really trained to really ask a very specific question. Initially, yes, open question, ask about HOPI a bit, but don't ask too much. And then you should focus on excluding out your differential. And then subsequently, in case you're missing out something, you ask about systemic review. And then after that, you straight away go to past medical history. Because past medical history, you need to ask a bit more. Like uncontrolled sugar, you got a lot of things to ask. Peripheral neuropathy, nephropathy, and also the retinopathy. You ask about microvascular complication, like for example, stroke MI, which you mentioned, and you also need to ask about any leg pain claudication, which is like leg pain or moving in particularly, that will suggest peripheral vascular disease. In men, you want to ask, do you have any issues in intimate relationship? That will suggest any erectile dysfunction. So all this comes in a bundle, and then you want to assess the medication. If let's say there is, you need to ask in detail any change in medication, any added medication, new medication, and then you also want to ask about the out of counter or traditional medication in particularly. Okay, it's all important. So after that, you go quickly to the family history, ask about any malignancy, any underlying chronic long-standing problem, medical issues, and then also ask about social history. So you should ideally, if you do everything in concise, by right almost reaching 6 to 7 minutes, you have almost finished your systemic review. Okay, you can spend about 5 minutes for the HOPI, and then about 1 minute to 2 minutes for systemic review. But generally, you shouldn't go beyond that. If you go beyond that, you will know you definitely not enough time to examine patient at all. You know how much of time you actually took to examine patient? 1 minute. It's just 1 minute, In exam, how you going to auscultate the lung, check for the leg, check for the abdomen, feel for the liver and spleen in 1 minute? It's not possible. And some more, this patient, you want to check for the breast. It's totally impossible. That's why I say the time management is important. You need to make sure that you time yourself by 8 to 9 minutes. You need to put your gear to a very, very fast gear, and then telling you that, okay, I'm just going to examine you. Is it okay? And then you just think as you go, okay? Because you need to be fast. You cannot get everything in the history, but you cannot score the examination. Because remember, history in the component station, right? In the component, I didn't put the component. Yeah, let's just use a Pravin one. So you can see that history is just under communication skill. You got all the history also. If you didn't examine the patient properly, they didn't score you full mark. You cannot that, and therefore you miss out on the sign. You also cannot score full mark. Which one is more serious? Actually, the physical sign and examination is more serious, because that is the one that's going to decide more marks than the history. History, you need to get important history. And how to get important history is you must have your own approach. There's no other way to train other than having your own approach. How do you approach the nephrotic syndrome? How do you approach abnormal kidney function? How do you approach newly diagnosed diabetes? This kind of thing. You need to really train your thought, because or else your thought process will only start when you start to ask questions. That is, if you think as you go, then that is too late. You will not finish the HOPI on time. So the idea is you need to be more fluent. You are actually fluent. It's just that you are not I would say orientated or concise enough to look for your differential diagnosis, or probably because you didn't think of the differential diagnosis. Okay, so you need to go do all that. And then yes, what I want to mention already. So if you're talking about nephrotic syndrome, right? So you need to tell yourself that this is nephrotic syndrome. When the patient have leg swelling, right, it's either liver, kidney, or heart, right? If you excluded liver or kidney, you excluded all the symptoms, then this is a kidney. And you also know that this is likely kidney because the kidney function is shown outside. So when you know that this is a so-called nephrotic, probably at that point of time you don't know whether it's nephrotic or not. That's why you did ask about any blood in the urine, any bubbles in the urine. It's fine to ask frothy urine. Frothy is not a jargon. Okay, frothy is just a normal term. Don't need to put to ask about bubble in the urine. You can just say, does your urine looks frothy to you? Then yes, yeah. And then do you notice any blood in your urine? No. So you think, and do you have any swelling elsewhere? Yes. Then you immediately you'll get all the facial edema, preorbital edema. Sometimes when the patient go for exam, the real patient with nephrotic, they are adequately offload, so they may not have very obvious swelling over the face or even the preorbital edema. So that can make the situation tricky as well. But you need to ask all that. And then when you divide nephrotic symptom, you should tell yourself whether this can be primary or this can be secondary. And then secondary, what are the things? Primary usually is minimal change, FSGS, and membranous. And membranous can be primary or secondary. Minimal change, actually all of them can be primary or secondary. But let's just, for simplicity's sake, divide them as primary or secondary. Secondary, you want to rule out drugs, in which you did. Malignancy, you miss. Infection, you try to rule out some of the infection, which is okay. But connective tissue disease, I only remember you asked me about joint pain. That's the only thing I remember. Maybe there's a bit of rash that you asked me as well, but it's not enough. You should ask things like, for example, do you have any mouth ulcers? Do you have any do you easily do you have excessive hair loss? Do you have any rash or any joint pain? Any muscle pain? So you should ask all that. Okay, you ask me. I remember there's some, but it's patchy and it's not really like thinking towards connective tissue disorder kind of symptom. And then don't forget that after you rule up drugs, malignancy, infection, and autoimmune, there's two entity in nephrotic syndrome in secondary that you need to exclude, is a DM and myeloma. So again, these two, DM is something you can ask. The history is suggestive, so you just need to try to see whether this is an uncontrolled DM with complication. And myeloma is difficult. Basically, you can just ask about back pain, hypercalcemia symptom, in which you ask about any polyuria in a way, any excessive urination, okay? And then you can also ask, do you have any kidney stone in the past? You want to ask, do you see any sand in your urine? Is difficult, okay? You can ask something like, do you have any pain in passing urine? Do you notice you pass out any sandy urine? You can ask things like that, okay? And then CRAB, right? Hypercalcemia symptom, you try to screen for that. And then anemic symptom, you explore. And then bone, do you have any bone pain? And that's all you can ask for myeloma from the history, okay? But in the investigation, we still need to work out. You can also send SPEP and stuff, but that one comes later if you have time. If not have time, you focus the important thing. So in this patient, is different. This is someone with nephrotic and with renal impairment. So you need to think about some other possibility other than all these common diagnoses. Okay, so you need to think something like, for example, is this patient having some form of nephrotic with AKI, right? So it can be some form of minimal change with acute tubular necrosis or acute interstitial nephritis, commonly associated with drugs, meaning patient have underlying nephrotic syndrome, and maybe because of the traditional medication used, then patient have renal impairment. Because the traditional medication only for 2 weeks, but this leg swelling has been there for 1 month. Another thing is that, like I mentioned to you, nephrotic itself is a prothrombotic condition. So you need to also make sure that not just ballot the kidney, also actually auscultate for any renal bruits. Okay, it's very difficult to find a patient with renal bruit, but let's say somehow this examination is being calibrated, then everyone will most likely miss because no one will routinely check for renal bruit. But in this kind of patient that you suspect renal vein thrombosis, you should other than balloting the kidney, you should also check for any renal bruits. And then this can also be due to congestion, too much of swelling, and then causing renal edema, intrarenal edema. Or it can be due to after treatment started on diuresis, patient developed pre-renal AKI because of dehydration. Or this nephrotic symptom can have some form of concomitant infection in the urine causing UTI. But I don't recall you asked me anything about foul smelling urine. Do you notice abnormal smell in your urine? I didn't recall that. UTI is something you must always exclude. It's also part of the infection that we screen. Okay. Other rarer causes, which just for knowledge purpose, not important for exam, is actually whether this can be some form of myeloma kidney, which is renal amyloidosis and probably with some light chain causing CAS nephropathy. That can also explain why the patient may have nephrotic syndrome with AKI. Or if this patient have a high risk behavior, have unsafe intimate relationship. If I have time, I will ask also, because nephrotic syndrome infective workup is also Hep B, Hep C, and HIV. So in particularly for secondary FSGS, there's this variant called collapsing variant, and HIV associated nephropathy or HIVEN actually associate with collapsing FSGS, and that can also cause nephrotic syndrome with AKI as presentation. Okay, one of the other thing is that, for example, those patients that have some form of glomerulonephritis that become aggressive and transform into crysenteric, that can also cause. But all that, I don't want you all to remember all these complicated things. These are all only important in clinical practice, but at least to me, at least the top five is something that you must came across, must think of the diagnosis and the differential, because those are the one that the nephrotic can present as AKI. Okay, this case may sound complex, but the key idea is, if you go by your approach, you shouldn't miss that, because if you go by approach, you want to know, go by the drugs. Yes, there is possible drugs. Infection, not really. CDD, not really. Diabetes, yes, possible. Then the malignancy, if you ask further, then you explore that actually she got breast lump, then you will also not miss anything. Actually, it's not a difficult scenario. It's just that you need to have your approach. This scenario is purposely designed by me to actually check your approach, whether you are thorough enough and concise enough with a given limited amount of time. Okay, it's possible. It's even possible to do this scenario under the old scenario, the old format as well. It's just how you approach the case. So my suggestion to you is that you need to practice more. You really need to practice more, and you need to try to make your HOPI more concise, and then you ask more about the, I mean, this patient chief complaint is what, this patient is leg swelling, right? You ask a bit more on the leg swelling, and after that start to exclude the differential already. Don't wait too long. Okay, for example, if the chief complaint is something like pain in passing urine, then you should ask all the urinary symptom as your HOPI, and then all the associated symptom, and then you start to exclude the differential. And then after you exclude all your possible differential, then you start to screen for your system review, just a bit only a system review, because most of that you may already ask in your differential. Okay, then you're done. You're done with HOPI and the systemic review. Then straight away go to past medical history. Don't drag. The idea is you don't drag too long. If you drag, the longer you drag, the longer you will compromise your component assessment in terms of physical examination and the sign. And therefore, it will also make you lose confidence, because if you imagine when the examiner told you you have 2 minutes left and you just about to start to examine the patient, you know how bad the feeling is in the real exam. You cannot imagine, because the feeling is something like you feel like you will fail the exam, even though the exam may well be carried on smoothly and you may still able to score, but that kind of impending kind of situation is something you don't want to face. So time yourself, tell yourself that you need to practice more, and then time yourself by 9 minutes. You really should prepare to examine patient. Okay, that's my take. Do you have any question, Q?
Yeah, I think I understand. Thank you so much.
You understand, right? So I don't mean to, disappoint you, or don't mean to kind of like give my negative comments, but the idea to me is actually to convey the message that whoever that attend tonight's session, campfire session is not a session for I would say to practice. It's a session to see everyone sit down together, listen at your own pace, to see how can we improve our own exam preparation skill. Because if anyone treating campfire as the only source of preparation for the exam, definitely it's difficult to pass the exam, because the only way to pass the exam is to practice, really practice, continuously practice. Because I think dietary will have a lot of people going for exam. This is a perfect time to find colleague that is also on the same boat and practice together. The only way is to practice and criticize each other. Then you will start to realize that actually, yeah, there's a lot of space of improvement for me to do, and you still have time, because now it's only mid-July and the exam is in October and December. So you have at least 3 months. 3 months is actually enough. You just need to optimize the time. Okay. And please don't be disappointed for whoever that try attempt today, because this is just and please don't feel shy or feel shame that you didn't do well. This is just a sharing session. It's not meant to reflect on the actual exam. I do it in a less exam style as opposed to Pravin, because I want to do it in a way that you all feel comfortable in doing it in your daily life. So if you do it in a real exam, you will even feel better. Okay, all right, that's all. If no question, we'll proceed with Hafiz. Hafiz, are you there? Can you unmute yourself, Hafiz?
Hello, hello.
Hello, yeah,
Hello.
Hafiz, can you hear me?
Yeah. I can hear.
Yeah, yeah. So you are okay, right, to proceed with the last scenario?
Okay, okay.
Yeah, so I think the time is a bit late for you, but actually, just to share a bit of my experience before we start your scenario, like just to chill down a bit after I say so many things. Yeah, so usually I practice when I prepare my exam, I actually practice at night, and I subscribe this one of the online tutor which is in the Middle East, and the time that I only can practice is actually start at 10 to 10:30, and my practice time is like until 2 o'clock in the morning or even 1 o'clock. Sometimes cannot tahan, go and sleep at 12 something. But you can see that these are the time that you are a bit tired already after the long day work, and then you are very tired. And sometimes if you are post call, it happened to me. I post call also. I'm still practicing at 10, so I didn't sleep more than 48 hours basically, and still continue to practice. And I tell myself that it's okay if you sacrifice the time. It's okay if you feel tired. Uh, if you can do well, if you can do at least be a very safe presentation, very safe and smooth kind of scenario, you can do well. Then in the real exam, your stress will be definitely reduced by half. When you go for real exam, you will feel more calm. Okay, so it's always good that if you all can spend some time also to practice out of office hour with your friends, and particularly with someone that is more experienced, because you don't want to, the blind leading the blind, what we call it. In a way, we want someone that actually can guide, and also can give a very useful opinion, and someone that already passed through the exam. Okay, so to cut the story short, let's proceed. I will have 4 minutes to prepare. Your time will start. Let me just prepare my clock. Okay, your time will start now. Okay, time's up. Dr. Hafiz, this is Mr. Razali. Please start.
Hi, Mr. Razali. I'm Dr. Hafiz, doctor in acute medical unit. How are you today?
Yeah, I'm fine.
I have been presented, I understand that you presented with increased urination for the past 6 months. Can you explain more about that?
Yeah, doctor. I noticed that for the past 6 months, I have been passing a lot of urine. I have to go to toilet frequently, day and night, and this really affects my daily activity.
Hmm. I understand this might be frustrating to you. Do you find yourself drinking more than usual?
Yeah, definitely. Because I think because I pee a lot, I also realized that I drink a lot of water. Talking about 3 to 4 liters every day.
So this also due to thirst sensation for you?
Yeah. I feel thirsty because after I
Mm.
pee, I will feel a lot thirsty.
What about your oral intake? Do you feel hungry all the time?
Not really. My intake is I feel fine,
Mm.
but my appetite I do feel lesser nowadays.
So you have less appetite.
Mm,
Do you feel headache or dizzy
no,
during the time?
no.
So this increase in urination occurs throughout the day and night. Am I
Yeah,
correct?
yes,
So do you have any painful urination?
no,
No, no pain.
no.
So what about the color of the urine? Is it bright or is it concentrated?
I think my urine is like water like that, as clear as water like that.
Water.
Yeah, it's very diluted, I feel.
Okay. So you don't feel any kind of in any sense of incomplete void.
No, I can pass my urine all out
Mm,
smoothly.
smooth. Okay. So have you sought any medical advice before this regarding this in the past 6 months?
I've been seeing GP for my diabetes lah, but for
Uh,
particularly for this issue, not really.
okay. So do you have blurring of vision?
Yeah, sometimes I feel for the past 6 months, right? Especially I have diabetes, so
Mhm.
my vision has been quite okay. It was under the eye doctor. It was told to just have some vessel changes. Does not need anything. But for the past 6 months, gradually I feel my vision is becoming blurred, both sides.
Both sides. Does it has, for example, do you have a problem when you hitting sidewalk?
No. I still can. I mean, it's like a blur, generally blur, like the
But
whole face
generally,
blur. Yeah, I still
both
can
eye.
walk. I still can walk. Yeah.
Mhm. Okay. So do you have headache?
No headache.
No headache. What about swelling in the body?
Swelling in the body, as in.
As in, you notice your abdomen is distended.
Sorry, what's abdomen, doctor?
Sorry, your tummy is distended.
I do feel my upper part of my tummy is a bit full.
Mm,
I don't know whether it's because of the air kind of sensation that I didn't eat much. Feel very bloated.
okay. What about rashes of the body? Do you have any skin rashes?
No,
Okay. Do you feel you have shortness of breath uh during daytime?
no,
Do you have any fever?
no.
What about joint pain?
Not really.
Mm, and chest pain? Do you have any chest pain?
No,
Okay. So you tell me you have diabetes and you went for GP. How long have you had diabetes?
so I actually have diabetes for 20 years. So I do have a bit of frothy urine in the past, and I feel my
Mm,
feet is already numb. This is my baseline, but I don't have any like major issue according to doctor. But initially I think my sugar was quite okay. I mean I was on Actrapid 15 units 3 times a day, Insulatard only at night 20 units. My 3 month sugar control was initially 7.2%. But recently, for the past 6 months, I'm not sure why it suddenly shoot up to 11%. And I have been seeing my GP quite frequently, almost 2 to 3 weekly to adjust my insulin. And now I'm actually taking extrapid 30 units 3 times a day and Isuatat 30 unit at night.
Okay. So regarding the so there is recently increased change in insulin for you. So
Yeah.
do you have any symptom of hypoglycemia, like you feel dizzy, you have
No,
sweating?
not really,
No.
not really.
So you check your sugar regularly at home?
Yeah. I've been checking my sugar 3 times
Mhm.
usually before breakfast, before dinner, and before sleep.
Mhm. What are the range in reading?
So usually my sugar value at home nowadays is actually easily from 10 to 20.
10 to 20. Okay. Um, have you had any surgery before?
No,
So you don't have any surgery. You don't have any kind of accident, motor car accident.
no.
Okay. I will ask a bit about your behavior and some sensitive question. Are you smoking?
I'm not smoking at the moment.
Mm.
I also non-smoker.
Non-smoker, never smoked before, right?
Yeah, no.
Uh-huh. Again, this is quite sensitive question, but I ask to all my patient. Do you take any alcohol?
Oh, no.
No. May I ask about your occupation, sir? What do you working for?
Yeah, I'm actually 65. I'm already retired. I used to work as
Retired.
a driver, but now I retired.
Okay. So, again, a quite sensitive question. Do you take any illicit drug or inject any drug?
You mean no, I don't do those kind of thing.
Mhm. Other than medication for diabetes, do you take any supplement?
Um, I do take some traditional herbs lah. After I feel unwell, but I only
Mhm.
take it intermittently, not very frequent.
So this is for how long?
I would say probably in the recent 3 months, but I don't take it every day, doctor. I only take like once or twice a week like that.
May I? So you take it for general well-being, isn't it?
Yeah, it's a general well-being.
No specific condition.
Yeah, I actually don't know what it's because it's all in powder form.
Powder form you buy from?
I buy from one of the shops that is it's not a pharmacy lah. It's just outside shop.
Or okay. So may I examine you, sir?
Can?
Okay. So first I would like to check the hand. Is there any clubbing?
No, there's no clubbing.
What about palmar erythema?
No palmar erythema.
Does he have any tremor?
No tremor.
Uh, I would like to check the pulse. Is the pulse regular?
Regular.
Regular, good pulse volume,
Yeah,
basically.
pulse volume is good.
Okay. I will check the face. Is there any pallor?
No pallor.
No puffy eyes. Okay.
No puffy eyes.
Mm. I want to check his hydration. What about the tongue?
The tongue is actually is a bit dry.
Dry. And mucosa also dry.
Yeah, because it's also
Mm.
dry.
Mhm.
I don't have
Uh,
photo with the patient, but you can see the patient is quite thin built, and then it's
mm,
quite thin in general. The muscle or the neck is actually wasted.
mm. Okay. So I would like to check the eye movement. Is there any abnormality in eye movement? I mean, extraocular muscle.
So you are going to perform a H test. H test
Uh,
is normal.
Normal. So what about the visual field?
Visual field. Okay. You want to do a Snellen chart? Oh,
Uh,
sorry. You want to check the visual field.
Confrontation.
Okay. Visual field is normal for both
Mhm.
left eye and right eye.
Mhm. Okay. Is there any neck swelling?
No neck swelling.
Neck swelling. Okay. Next, I would like to examine his chest. Is there any trachea deviation?
No, no trachea deviation. Trachea is central.
What about the entry of this patient?
So when you auscultate the patient, there is an equal vesicular breath sound. There is no crepitation or bronchial breathing.
What about during percussion or
Percussion is just resonant all the way.
okay? CVS, we have to check the apex.
So you want to listen for murmurs. You don't
Uh,
appreciate any murmurs.
Okay. We'll continue with abdominal examination. Is there any abdominal mass?
So when you sit down and then when you palpate the patient at the same level of your hand, so you feel like there is some epigastric mass.
Okay. So is it firm or hard?
It's a firm and then it's firm in consistency, and then the margin is actually very clear, but you cannot able to appreciate the upper border. It does not really move with inspiration.
Okay. It's non-tender, right?
No, when you press on it, the patient safe a bit full, but it's not really in pain.
So can I examine for ascites with this patient?
So when you do a shifting downwards, it's negative.
Negative. At this point of time, I would like to do urine dipstick for this patient.
Okay.
To look for proteinuria.
Okay. Anything else?
And then I would like to check the GST, bedside sugar for the patient.
Yeah. So baseline sugar is actually 20.
20. I would like to check the lower limb for pitting edema.
There's no pitting edema.
Okay, next I would like to check the back. Is there any rashes or sacral edema?
Back, there's no sacral edema, no rash.
Okay. So, may I ask, Mr. Razali, what is your concern today, Mr. Razali?
Doctor, actually, what do I have? Why I'm been having this excessive urination?
So, this excessive urination, based on my our consultation, I would say two things. First, regarding your poorly controlled diabetes. So this may contribute to your what we call osmotic symptom, which is polyuria or increase in urination. That is one thing. Another thing,
2 minutes left.
we need to investigate your abdominal swelling.
Sorry. Why is abdomen again?
So your tummy swelling. Because it may raise suspicion of malignancy. Malignancy, which means there is a possibility of cancer. So some cancer may cause release of hormone that may lead to a form of endocrine abnormality. So this hormone may cause you to pass a lot of urine. That's why we will investigate and admit you to our ward for hydration, for further investigation, in order for us to get to the bottom of this. Do you have any other
Doctor,
concern?
why my sugar is not controlled?
So again, there's problem with your hydration, which means that your body is does not get
But doctor,
proper.
I'm taking insulin all the time as per doctor prescription. I also increase the dose at what the doctor recommended. It's still uncontrolled, doctor. I've been following the doctor instruction.
Yes. So what we will do is actually monitor your sugar in our ward and also adjust insulin accordingly. We will refer to you to endocrinologist for further investigation.
Okay. So I'm actually staying alone most of the time.
Mm-hmm.
I'm actually all my children is working most of the time, and my wife had passed away.
Mm.
I'm worried if I become unwell, what should I do? Can you help me for this?
Okay. We can refer you to welfare and discuss about your
Okay,
work.
time's up.
Mhm.
Okay, time's up. So, Dr. Hafiz, would you
Yeah.
mind to go through positive significant history that you gather, and then followed by positive physical examination finding? Only then you tell me about your provisional and your differential diagnosis.
I have Mr. Razali, 65-year-old, presented with increased urination. Increase in water intake or polydipsia. He is also has underlying diabetes mellitus, which is poorly controlled and having target organ damage, like blurring of vision and proteinuria. Based on my examination, he is dehydrated and he's having abdominal mass. I would like to investigate regarding the poorly controlled DM and also
So your provisional diagnosis is?
provisional diagnosis. First is poorly controlled DM. Second would be
Sorry, poorly
diabetes
controlled DM because of what?
because of uh, I'm not sure about that. But the abdominal mass, I would like to investigate for malignancy to up
So you
uh,
mean the uncontrolled
mm,
DM due to malignancy?
mm, poorly controlled DM due to possible traditional medication.
Okay, possible.
And um,
How about
I also
malignancy?
need I also need to investigate for diabetes insipidus and link with malignancy.
Okay. You have mentioned that the patient is fully controlled diabetes, but he told you that he has been compliant, right? And then
Mm-hmm.
any other cause to explain this in as part of your differential?
Um, um, I'm not really sure.
Not really sure. Okay, it's fine. Okay, so how do you investigate this patient?
So for investigation, I would like to send for renal function to see the electrolyte. If there is any abnormality in electrolyte and correct it accordingly. I will also send urine sample, check for example, urine FME, to check for specific gravity, and then urine osmolarity, serum osmolarity, and urine sodium, because I would like to uh, see whether there is increase in serum osmolarity and reduce in uh, urine osmolarity to see uh, s- uh, si- sign of diabetes insipidus on this patient. For imaging, I would like to order abdominal ultrasound to see the swelling, whether it is some form of gastric or gastric malignancy.
Mm-hmm. Is
Mhm.
there any other investigation in
Mm,
terms of blood that you think may be helpful?
For the diabetes, I would like to send the fasting glucose and HbA1c to see his level.
Mm-hmm.
And then full blood count to see anemia, white cell count for to rule out any infection, and liver function to see if there is any uh, hypoalbuminemia.
Okay, how will you manage this patient?
I would admit him and then start on hydration and involve multidisciplinary team. I would consult endocrine for his sugar control and also investigation for diabetes insipidus.
So you
Other thing,
you want to change your provisional diagnosis to diabetes insipidus?
yes.
But what is the cause of the diabetes insipidus?
Mm,
Okay, time's up.
okay.
How do you feel about this scenario?
I think the history is not that clear because I didn't explore much about it.
Mm. So when you cannot get a diagnosis, like you're not very sure of the case, it's either you miss something in the history, or there's something that you, I mean, there's some diagnosis that you are missing to in order for you to actually trigger you, because sometimes the scenario is very straightforward. You will be very confident to tell the provisional and the differential, but this one is very like fishy, right? So what do you write outside when you prepare the scenario? Polyuria. What is your
Mm,
approach?
so I want to exclude things like
Mm-hmm. You want to exclude what? Hello, Hafiz? I think something wrong with your line. Hello, Hafiz, can you hear me? Hello, Hafiz, can you hear me? And what else? Is there any issue in my audio? Probably just give a message in the group so that I can hear whether am I talking to myself, or you all can hear. Okay. So I think Hafiz is disconnected. I don't know, but his name is there, right? So, oh, he's disconnected. Let's just give him some time, because he have done his part. He have tried his attempt for this session, right? Let's just give some time before he rejoin back. Anyone have any question before we move on? Yeah, he's typing in the group, but I can't. Yeah, let's just give him some time to sign in back. Hello, Hafiz, can you hear us? I saw you're back.
hello. Okay. Okay. Sorry.
Yeah, you are back. Okay, sorry. It's
Uh,
okay. We wait for you. Since at this time everyone is like half asleep already.
no,
Okay,
no.
so what do you wrote when you prepare the scenario for polyuria? We are all
Uh,
interested to know.
Actually, I would like to rule out infection, like urine tract infection, and then
Okay.
primary polydipsia, regarding his own water intake. Mm, but I cannot relate within apa, polydipsia
Okay. Never
with
mind. Just
macam
just
benda
just
apa.
make it short. You have mentioned UTI. You mentioned DI. Is there
Ah,
anything else?
hmm,
Differential diagnosis, because you must write a good differential diagnosis before you prepare the case. So when you write the scenario, patient
mhm,
name, you write Mr. Razali, just in case you forgot the patient name when you go inside. It's very disappointing. So you write
mhm.
Mr. Razali 65, polyuria 6 months. So differential diagnosis, what do you write other than this UTI and DI?
I only got those two.
I mean these two cannot. Okay. I can see you have efforts. I can see that you are actually you have been practicing, right? Am I right?
Quite a bit.
Quite a bit, right? I can
Hmm,
see that you are a bit different compared to other three, because you stick to your time. And I don't know whether because you learn from them, but I can see that you stick to your time, and you also quite concise when you ask question. That is very good. You are almost there in terms of exam preparation, but you need to brush up in terms of your approach, because I can see that you cannot really give me a very good differential diagnosis for this
mhm, mhm,
scenario. Okay,
mhm.
So you see, everyone, if you all cannot remember anything, everyone is so tired. Just remember three things. When patient have polyuria, rule out these three things first, because this three things is the most common uh, explanation for polyuria. Number one is your so-called DI, or arginine vasopressin deficiency or resistant. Nowadays the new term is called AVPD or AVPD or AVPR. Whether or not it's just DI lah, huh? Number one is DI. Number two is hypercalcemia. I did not listen to any of hypercalcemic symptom that you try to exclude. Okay, so you need to rule out hypercalcemia. Number three is the sugar. So this three is like important thing, most important thing. The rest of it, for example, drugs like for example lithium, underlying bipolar or some mood disorder. Yeah, that's another thing that can contribute to be so-called nephrogenic DI. But that is not the important thing. Important thing is this three. Okay, so you expand from there. You have to write this DI. It can be DI. It can be high calcium, arrow up calcium. It can be arrow up sugar. Okay, so high sugar or high calcium. So you expand from there. If DI, if nephrogenic, if central, what is the cause? So if central, you're thinking about hypothalamus or pituitary lesion. So on the root of vision, things like that. Yes, you thought about that. And then if it's like peripheral, and bear in mind that it's not just obstructive symptom. You also want to ask more symptom. For example, you want to ask for any excessive growth hormone, any excessive ACTH, any excessive TRH, any excessive FSH and LH. So all these need to be mentioned. So you need to exclude whether patient is acromegalic or not, whether patient is Cushing disease or not, whether patient has any evidence of hyperthyroidism or not. So you need to ask all the symptoms for the primary, also called central. Okay, and then next is actually your nephrogenic DI or AVP resistant. So you need to explore whether patient got any drug usage most commonly, and any recent change in medication. Those you can wait until you ask the drug, only you specifically ask for that. But if you don't remember, also you follow a general approach. Whenever patient on any medication, ask about the dose, any recent increase or change, any added new medication, and then ask about traditional medication and also over the counter. That's the standard. Okay. Next thing is your hypercalcemia. So hypercalcemia can be because of can be due to PTH dependent or non-PTH dependent. So hypercalcemia can be due to primary hypercalcemia, for example, FHH. If patient is younger age, this symptom has been recurrent, then this can be FHH, familial hypocalciuric hypercalcemia, or it can be primary hyperparathyroidism. If it's secondary, it can be due to secondary it can be due to back to primary, other than primary hyperparathyroidism, it can also be tertiary hyperparathyroidism. So must make sure patient have any kidney functions, kidney check before. Does the doctor tell him that he have any kidney problem in the past? Okay, so because tertiary hyperparathyroid also can have hypercalcemia, and then subsequently it's a secondary hypercalcemia. So want to rule out sarcoidosis, want to rule out TB, lymphoma, and also drugs, vitamin D, and also things like pheochromo, although it's not common. So all these things need to come into the picture when you approach your hypercalcemia, secondary cause, for example. So you want to ask about family history a bit later on. You also want to ask about TB symptom. So you also need to ask a lot, okay? It's not just about that. And then lastly, you ask about sugar. Okay, so the thing that does not tally with this patient, if you remember, the history is diabetic for 20 years with good control. However, for the recent 6 months, the HbA1c suddenly jumped from 6 to 7 something to 11. Does it strike you anything at all with this kind of history?
Okay.
What do you mean by the answer? Not Yeah, full of wisdom. Do you have any thoughts on this? Okay. So you can see that this kind of patient is also quite common that we may see in clinical scenario. It's not just for exam purpose. I hope everyone after this session, whoever attended, can realize that sometimes a lot of uncontrolled DM patient that we manage, we have to assess properly whether this is due to their compliance issue, whether this is due to their insulin injection technique. For this kind of patient, it's unacceptable if you don't check for lipodystrophy over the abdomen. Okay, it's unacceptable. You must check, because how you know that although they are injecting, whether they are injecting in the correct technique, that that cause a lot of lipodystrophy already. Therefore, the insulin absorption is not good. We don't know. So you need to check. Although he says compliant, so you must exclude his compliance, exclude his using the the injection there, whether there's any lipodystrophy over the abdomen. Let's say there's not. Okay. The next thing is you must work out for secondary DM, because you see, if a patient with a well-controlled DN suddenly have increased insulin requirement, suddenly have surge in the HbA1c, and they have been so stable for the past few years and suddenly become like that, you really need to rule out secondary DM. Do you know what is mean by secondary DM? It's not type 2 DM, it's a secondary DM.
I was like pushing.
Yeah, correct. Cushing. Anything else? Endocrine cause can be Cushing. Yes. Anything else?
Hyper or hypothyroidism.
Correct. And acromegaly, the three common one. Fear also can cause, but less common. But these are the three endocrine causes that we need to rule out. So you must also screen for all those symptoms. You see, it's not just enough to, oh, I think this patient is uncontrolled diabetes. That's all causing polyuria. But what causes a uncontrolled diabetes? Having stable for so long. So endocrinopathy can be explained, can be causing secondary DM. Okay, later we'll talk about that. And there's also in this patient, there's a red flag there. There's epigastric mass. You think this is a stomach cancer? What are the other structure in the epigastric other than stomach?
Gallbladder.
Other than gallbladder?
Liver.
Okay, left loop or liver. Other than liver?
Pancreas.
Yeah, pancreas. Now does it ring a bell to you? What happens if someone have pancreatic insufficiency on top of DM? So patient sugar will be worse, you see, because the functional unit of those beta isolate cell will be less because of pancreatic insufficiency. And then the moment a patient that have weight loss and increasing insulin requirement, this kind of patient is having catabolic state, which means they have not enough insulin. Okay, this kind of history should trigger you to work out for pancreatogenic causes of DM. You see, so you must make sure that you're not dealing with something like chronic pancreatitis. You're not dealing with some form of pancreatic malignancy. You see, this is very important because this kind of scenario, I don't know whether come out exam before, but this is something that I design in a way because I think we need to be aware that we need to really have a proper framework when you work out for all the common chief complaint. So secondary DM, the usual exam scenario that come out is actually suddenly become uncontrolled the sugar and and then give you a classical acromegaly patient. Nothing exciting, everyone will score. But this kind of scenario is a scenario that you will easily miss and you will not able to score because it's not obvious unless you screen for it. You see? So that's why it's important to think of pancreatic malignancy. There's a lot of hint to pancreatic malignancy already. The only thing you didn't exclude in this family is the only history that you didn't explore is actually the family history. I didn't notice you ask anything about family history at all. If you ask the patient have strong family history of DM only, that's the only history. But you also want to explore, is there any cancer in the family history? Okay? Because you know why pancreatic cancer can also be associated with MEN1, can also have some form of hereditary causes like IPMM and all those rare condition. Regardless that, family history is important aspect. Okay? So this thing is important. And you did ask about tummy pain in which you ask like abdominal pain. So don't use the abdominal pain. It's a jargon. You get the moment you mention a jargon, they can potong one marker already. Then it's kesian already. Then if two examiner potong one marker, it already means 2 marks. 2 marks mean a lot in exam. Even 1 mark is like precious 1 mark. You want all the marks. Okay, because you will not able to predict that sometimes you will lose the mark somewhere else that you least anticipate it. So that's why every marks is important. That's why if possible, try not to use any jargon. You have used a few, you use abdomen a few times, you use incomplete voiding. This is also a jargon because it's not a layman's term. Okay, just use a simple term. Don't use a jargon. Okay, so you get most of the history, but the problem is that you don't know how to tear out the finding. And then this kind of patient with the traditional medication, you also want to look for Cushing features. And I told you the patient got some wasting of the muscle. You should tip you off to think, can this be cachexia? Because thin body build. And if you are worried that the patient is cachexia, sometimes you can even request for BMI, but not necessary to look for so-called underweight, right? And then the warning sign for this patient is actually epigastric mass. And if you think of this, I didn't carry back that, but actually another important point that I feel important is to check for lymph nodes if you have enough time. And this kind of uncontrolled DM patient, I thought you almost have it, because if you say someone uncontrolled, right, you also want to screen for complication with enough time. So when you check for the pedal edema, just press like that, right? I expect you to actually offer to check for the pain. Just take the monofilament and then just poke a bit. It's okay, don't need to go by dermatome also. Just go up, do you feel numb? And then you just go up whether there is any peripheral neuropathy. That's to screen. Because you know the patient got all the end organ damage, like you say, TOD already, target organ damage. So you want to make sure that the patient is really having uncontrolled DM. And the abdomen, important thing is the lipodystrophy that you need to check. Okay, so the differential analysis for this patient is actually uncontrolled DM. And what is the cause of uncontrolled DM? It can lead to possibility of pancreatic malignancy. Can still be non-compliant, but patient says compliant. Can still be some form of chronic pancreatitis. Sometimes chronic pancreatitis may not have pain, but one of the symptoms important that you want to actually exclude is whether there's any steatorrhea, any oily stool, any greasy stool. If you ask me in detail, I will mention to you, but I don't recall you asked me whether there's any change in bowel habit. Do you ask me?
No.
Yeah, so that's important, huh? Because bowel symptom is quite important, especially you think of GI malignancy, right? And then it can also be drug-induced TCM like that. If you think that this is a pancreatic malignancy, right? Then yeah, and I think that if you think this is a gastric malignancy, how does it cause polyuria? Then you can think of like possibility of hypercalcemia of malignancy that causes polyuria. That's a possibility, no doubt. But if you don't have any hypercalcemia symptom at all, this is uncontrolled DM. This suggests some form of pancreatic insufficiency, and you need to sell that this can be due to pancreatic malignancy. And then your workup will be something like VBG ketone, renal function test. And bear in mind that I like the way you present. When you mention a test, you should justify it, not just good enough to mention all the baseline tests. So you want to justify that whether there's any anemia, whether there's any liver injury, whether there's any AKI, whether there's any evidence of DKA, and then UFAM quantified UACR, H3A1C. And in this particular patient, because I'm suspecting chronic pancreatitis, I want to do a amylase just to see the function. And I want to take a CA19-9, ultrasound abdomen, CT tab, as well as EUS or ERCP, because this can potentially be due to pancreatic malignancy. Then the management will be MDT, counseling, admit to optimize the sugar. You say if endocrine is not wrong. And then you have to refer for urgent imaging if you are thinking of this is a malignancy. And then other than the control of the DM, you should also subsequent management will depend on the condition. Will involve the surgical and oncology team to explore the options. And you can also refer the dietitian, counsel, diabetic nurse to assess the insulin injection technique, and also refer to the OTPT, dietitian just to optimize the nutrition. So all those you can goreng, no problem. But the important thing is you still need to mention. So that's why this scenario is a bit tricky, I would say. It's not straightforward. But how do you get a diagnosis? How do you not missing a diagnosis is I'm going to discuss. When you encounter any patient with polyuria, think on this top 3 first. The remaining 2 is rare, but this is something you want to write. And then if you really excluded Gao, you cannot, then you should offer. So DM, you want to put DM or DI or hypercalcemia, whichever number 1 is fine. But the general cutoff is, I think you should all screen for all these symptoms. If the patient have DM, uncontrolled DM, which is previously controlled, or this is some form of newly diagnosed DM, you need to screen for secondary DM as well. So you must ask about all those symptoms. And DM, in this age group, probably not, but young onset DM, you should consider whether this is possibly a type 1 DM. And then always remember in exam, in PACES exam at least, when you encounter a type 1 DM patient, you must automatically screen for autoimmune polyglandular syndrome. If you do that in exam, you will also do that in real life. And when you enter the endocrine posting, this is also like a spinal reflex. You will check for the cortisol to look for Addison's disease. You will also check for the anti-TPO and stuff like that, thyroid function, to look for any autoimmune thyroid disorder. So if patient have features of type 1 DM, check for autoimmune polyglandular syndrome. Okay. If it's type 2 DM, then fine, assess the complication and the control. Okay. Then hypercalcemia, you must ask that you ask a lot about the tummy pain. You also ask about whether there's any vomiting, any racing or pacing of the heartbeat, any confusion, any stones in the past, like kidney stones, or do you have any confusion? So all those will suggest hypercalcemia. And hypercalcemia in patients favored is always to screen for all these causes. And if this is a primary hypercalcemia, right? What I want to mention is that hypercalcemia, malignancy is something we need to screen. TB, sarcoidosis, like I mentioned just now, hyperparathyroidism or hyperthyroidism. MEN1 and MEN2A is important because of parathyroid hyperplasia. Bear in mind that in hypercalcemia, you also need to screen for hyperparathyroidism. So hyperparathyroidism can be primary or secondary. Right? If it's primary other than the one that I mentioned, FSH, the one that I mentioned, primary or tertiary hyperparathyroidism, also remember about the hereditary parathyroid hyperplasia, which is the MEN1 and MEN2A. Okay, so DI can be AVPD or AVPR. If it's AVPD, you try to elicit any brain injury, any surgery done, any infection. Okay, and then sometimes can happen also after like delivery. So all these things need to excluded. And then AVPR, the resistant, which is the nephrogenic, but it's mainly due to the drugs. Although it can be also due to Conn's syndrome, Conn's disease, but it's not that common. And then yes, you talk about primary polydipsia, it can be psychogenic because of excessive drinking, but this is like a diagnostic exclusion. If the patient is not drinking more than usual, like you're talking about, in order to develop psychogenic polydipsia or primary polydipsia, you need to drink at least 16 liter if your kidney function is improved, is normal, right? So it really drink really excessive enough, or else it won't actually cause primary polydipsia. So I think the primary polydipsia diagnosis can only come when the patient really drink a lot, like 10 liter. At the same time, the mode also got some symptoms, feel depressed. Okay, then you must put the DI, as in the primary polydipsia as part of the differential. Then number 4 is the drugs that I mentioned. Bear in mind that steroid can also cause polyuria. The last one is the rare one. So far, it's so rare that probably most of us will not put as a differential. It's actually the renal tubular acidosis. Sometimes RTA, they can have hypercalcemia symptom, and most of the time their presentation is just limb weakness, some form of paralysis over the distal limb especially. And usually they have some family condition, family members that have similar presentation. Also, they may have a kidney stone. Okay, so these are all approach. These 5 things, or if I want to, if you cannot remember all 5, right, just remember the first 3. Whether it's a sugar problem, whether it's a calcium problem, or whether this is actually a DI. Okay, so how do you approach with secondary DM? So if you classify it, you can make it simple. It can be endocrine causes, it can be pancreatogenic, or it can be drugs. Okay, if it's endocrine, it's just Cushing, acromegaly, and thyroid. I like to use the mnemonic like CAT, right? So it's like you use all this to screen. Okay, you can even classify them further if you want. Like for example, whether it's a weight gain or weight loss. If it's a weight gain, it's a Cushing, acromegaly, and hypothyroid, and also polycystic ovarian syndrome. Usually they're obese. If it's a weight loss, then you're talking maybe about hyperthyroid, pheochromocytoma, okay, or even primary hyperaldosteronism. But having said that, pheo and primary hyperaldosteronism can be weight neutral. They don't really have much weight change sometimes. So the idea is that you need to screen for at least 3, Cushing, acromegaly, and thyroid. And then the pheo, primary hyperaldosteronism, all those are quite rare. And in female, you might need to suspect polycystic ovarian syndrome because they tend to have infertility. So this is something that we need to think about, and they're usually obese. And for pancreatogenic, like in this patient, you must screen for 3 things. Okay, the first 2 is more to adulthood. The last 2 is more to young adulthood, or I would say young adults or children. Okay, so chronic pancreatitis and pancreatic cancer for this patient, because the age group is high in suspicion, it's really high. Okay, may or may not have jaundice depending on the severity. And don't forget cystic fibrosis and hemochromatosis, because these 2 can also present as uncontrolled DM, and this uncontrolled DM can subsequently manifest as polyuria. So hemochromatosis is something that you need to think about when you're dealing with young adults or even more like a children, teenage group, and can sometimes be manifest late, like in middle age. But these are the things that you need to consider when you write in a scenario. If you don't want to write, right, then you have to write in your brain when you do the mind mapping. So when I think about uncontrolled DM or secondary DM, these are all the differential I will come into my mind. I will divide into these three categories. If I cannot remember, I will just scratch it out in the paper before I forget to ask. Okay, drugs, commonly those that can trigger pancreatic injury. For example, steroid. We know that steroid can precipitate the sugar. Azathioprine, cyclosporine, PDL1 sometimes can cause some form of pancreatitis in a way that they cause pancreatic insufficiency. So these are the approach. So you must have an approach. If you have an approach to the scenario, you will able to get. I know that this is like a multi-level thinking. So the first level is like what causes what causes the polyuria, and then subsequently you delve further depending on the history. Okay, which one is positive, and then you go towards that history. It's not difficult. It's just that you need to think of it. This kind of differential diagnosis must be in your list in order for you to think of that as your answer, right, in an exam. Okay, Hafiz, do you have any comment? Anything you want to ask?
No.
You understand, right?
Okay.
Yeah. So everyone, any question? May I ask if nephrogenic DI secondary 2 and hypercalcemia are they considered two differential? And when being asked to give differential, should we focus on polyuria or hypercalcemia? So again, you have to know that polyuria is not a diagnosis. Polyuria is a sign. A symptom is increased urination, right? Polyuria is a sign. Okay, and then your diagnosis cannot be polyuria. So your diagnosis is what causes the polyuria. So that's why if you want to offer a diagnosis for this patient, you can say that my provisional diagnosis is uncontrolled DN secondary to all this possibility. If the examiner asks you if that's not an answer that they want, they may ask you further. They will say that other than uncontrolled DN, is there anything else? So you must listen to the question properly when the examiner asks a question, because they usually don't simply ask you, they want to score you. And sometimes when you are in the wrong track already, they want to dilate you back a bit. So you must listen properly. Let's say the examiner did not ask you what are the other causes or what are the other diagnoses other than just uncontrolled DM because of all this. Then yes, you say, yeah, there's also a possibility of hypercalcemia. However, from the history, I did not able to elicit. And there's also a possibility of diabetes insipidus. However, from the history and the presentation, it actually lower down in my list. You can mention something like that. But in this kind of scenario, there's something more obvious that strike you not to think of other thing. You can mention, to me, I will accept that you think this is hypercalcemia due to possibility of GI malignancy because of the epigastric mass. I think we can accept that. But again, whether there's any hypercalcemia syndrome, actually that is not, other than polyuria and polydipsia alone. Okay, but it's still a possibility, still can be accepted. But the more urgent and pressing thing is you want to rule out the danger and the more severe one, which is the pancreatic malignancy lah. Okay, all right. Is there any other question? If not, then we will end our session today. Can lung cancer be differential for this case? Are you referring to the last scenario just now? I'm not very sure. But lung cancer for this case, probably not, because the symptom is polyuria. Yes, true enough. Usually lung cancer is more to SIADH instead of DI lah. Oh, so lung cancer, the SIADH, usually all the small cell lung cancer, they tends to present like SIADH kind of picture, in which will not come out in exam. Don't worry, it won't commonly come out SIADH like that. It's more like a clinical history and sign that we need to appreciate and then come to a diagnosis. Okay, so again, I think today everyone's have tried your best. I know that it's a tiring night. It's quite lengthy, I would say. Yeah, I don't know whether I can do any other session because later on I'm going to be very busy. But I hope that every one of you that's listening to this recording later on or even now, try to practice more. Don't expect this kind of like 1 or 2 times per month session will help with your exam. It will not, because this is just mainly fine-tuning. You can see what I do is mainly fine-tuning, and also try to share some experience that how we can do our exam better, how we can score better. Okay, anyone else? I heard someone want to mention something, right, or ask a question. Okay, so everyone clear? Yeah? If not, then